In January, I discussed three areas that I thought would see significant advances in lung cancer. The first was the propagation of high-quality lung cancer screening programs. The second were advances in the use of minimally invasive tools for staging and for treatment of early-stage lung cancer. And the third was an increase in our knowledge of the molecular characteristics of lung cancer, allowing us to personalize treatment more. I don't believe there's been much change in those latter two, though I don't have any empiric evidence. I do believe those continue to be advancing throughout the year. The greatest change would be in the way we're thinking about lung cancer screening. In January, fresh off the USPSTF's recommendation to screen age 55 to 80, 30-pack years, we were optimistic that CMS would approve coverage for the Medicare population. CMS asked for advice from their MedCAC group, and the advice was less positive than we would have hoped. We're still optimistic that CMS will provide coverage, but with that, I suspect will come a lot more restrictions on the type of program that they will deem high quality enough to suggest insurance, and in particular Medicare coverage. I think by the end of the year we'll have those programs in place, and I look forward to CMS's positive decision, but it's much less well known what they will say compared to January.
There are organizations like NCCN, the Academy of Chest Physicians, the American Thoracic Society, who are all really supportive of lung cancer screening in this targeted high-risk population. And I think all of those groups are meeting with the Medicare, Medicaid decision makers to try and support lung cancer screening. So we have a high level of confidence that they're not going to create these two tiers of who has a better chance of surviving lung cancer versus people who don't have insurance coverage.
Very happy to report that since January, we went from 10 centers across the country to 45 centers performing 3D surgery. That includes general surgery, OBGYN, and of course, thoracic surgery.
Earlier, EGFR and ALK were the main stories of the year. We've seen this continue after ASCO. While at the meeting, 3 separate inhibitors of the resistance pathway to EGFR were presented. This included the AstraZeneca compound, the Clovis compound, as well as a compound from Korea, and all of them showing very interesting activity and slightly different side effect profiles. We all anticipate that one of these drugs will make it to market probably by next year, and again will greatly change the management of patients with EGFR mutations. We talked about ALK. ALK is still full steam ahead. We have several drugs to choose from now regarding ALK inhibitors. And then finally, immunotherapy. We can't get around immunotherapy. It's still ongoing. A lot more data being presented in multiple cancers. It's a prediction by many that, in fact, there are going to be multiple immunotherapy compounds approved in the next several years. I hope this is the case. Again, I think we still need to find that optimal biomarker.